data science meetup, I thought it would be appropriate if we dwell into some of the things that are pretty much open challenges. So that's basically where I'm just randomly firing ideas which could perhaps ignite more conversation around these topics. So that would be the rough template of what I have in mind today. So let me start with what's Medo.ai. So basically, we are a startup focusing on AI and ultrasound. So the objective here is to see if we can add value to the domain of medical image analysis by automating the interpretation process. And how do we automate it? Basically, by using techniques from AI. Now, let me start with this slide, where I basically try to identify the key issue that we have in the AI system. So if you were to typically look at what happens right now in a healthcare scenario, you start with a symptom. So a patient, could be anyone, has a symptom. From there, you go to what is called point of care, which is literally the first place you contact a doctor. So depending on where you are, it could be a different location. So for example, in case you have a disease and you want to consult your family doctor, that would be the first point of contact. That would be point of care. Another scenario would be, say, in a military circumstance, point of care would be in an emergency department. So you have the point of care, which is the first point of contact with a medical practitioner. From there, you go to a tertiary center. Now, why do we go to the tertiary center? It's essentially for medical imaging. And here was the first shocking revelation that we had, that 2/3 of the world's population just doesn't have access to this tertiary center, which basically prompts the question, what happens after that? So from the tertiary center, let's take an example of an MRI scan. So you have a condition, which is your symptom. You go to the point of care, which is your family doctor. You tell him that this is the problem, and then you go to the tertiary center, which is basically where you would do your blood work and things. You're still not at the point where you got the MRI scan. And you're talking about, in each of these steps, you're talking about timelines of months. And you eventually reach the radiology department. There's imaging, an expert views your scan, and then you have diagnosis and treatment. Now, you can already see the problem here. This is a long, drawn-out process. And it costs a lot of money. It basically takes a lot of time. So what are we trying to do here? We're basically trying to democratize this problem by bringing more value at the point of care. So to put it in simple terms, what if all these things could actually get started from the point you go to your family doctor or from an emergency center? So that's basically the motivating thought behind Medo.ai. So where did we basically start? So this is a bit of history about myself and about my colleagues and about the founding team of Medo.ai. So we were rooted deeply in research, and I was a postdoc at the University of Alberta in the Department of Radiology. So was our CEO, Dornush. And we were working with our co-founder and CEO, who is Dr. Jacob Jaremko. So one thing that we noticed there is that there is a real need to make medical imaging more accessible. And there is a real need to basically see that we are able to add value by reducing the time that it takes from the point of a symptom to the point of treatment. So with this objective, we actually started a collaborative, and the first obvious idea, since we were in a hospital, was to join hands, basically bring in more hospitals together. So CUDL, which is expanded as Collaborative for Ultrasound Deep Learning, was the first collaborative in which we basically tried to organize a set of 10 leading hospitals across the world. And the idea was to have this platform where we could actually share information, where we could share images, where we could basically work together and try to solve this problem. And that was on for a year, more than a year. And that's when we actually realized that this has something missing, which is an industrial component. Because we actually see a lot of potential in this problem, yes. But for a problem of this scale, you need a team. You need basically to tackle it as an industrial problem. And that was basically the motivating thought that led towards what Medo is. And so we basically tried to start from this collaborative, and then we move on to what we do at Medo. And at this point, it was about medical imaging. And some of our collaborators in CUDL actually moved towards other modalities. And we chose ultrasound. So next, I'll explain why we choose ultrasound. So if you compare the prevalent imaging modalities like CT or MRI, It costs millions of dollars. The equipment is exceedingly bulky. It barely fits into trucks. So, I mean, there are MRI machines that go around in trucks, but that's not something that is going to be commonplace. But ultrasound is literally the only portable modality. And right now, most of you have a picture when I say ultrasound, which is about the ultrasound that's used in fetal scanning, which is about a machine. But right now, when you talk of ultrasound, you're talking about a device, the kind that you see in the screen here. So this is an actual ultrasound device. It's literally handheld, and it can be carried around in your pocket. And this can, and that picture is to scale. So that can actually communicate with a phone. So the issue of a portable modality is solved. Ultrasound is a portable modality. It's truly portable. It can reach every patient at point of care. But the big issue is interpreting ultrasound is exceedingly difficult. And why do I say this? Let's try to compare this with what happens in MRI. Now, if you're not from a medical background, the easiest way of thinking about an MRI image is as though you're looking at an image of a person in a room with a light overhead. So you see the entire person, you see the entire anatomy, you have the whole context of what the body is there. As opposed to ultrasound, which is pretty much like flashing a torch in a dark room. So it's pretty much like this. And based on where your torch is, you see this tiny window, that's the image. So if I were to show you just this part, without a medical background, you would have literally no clue which organ we are trying to image here. And the other problem is it's a handheld device. So there is no such thing as a global coordinate system where you can point to where that image corresponds to in space. So it is, in many ways, a way more challenging modality than MRI or CT. But the reason we do this to ourselves is because there is a huge potential here. Like, if you look at the reach of the ultrasound device, it is unparalleled. Ultrasound is literally the only one that can actually go to point of care and address the initial problem that we were looking at. So just to summarize all that I was explaining, with ultrasound, we have a point of care modality. So the device is there. Yes, check. We do not have the expertise to interpret ultrasound. Yes, you have the expertise in the hospitals. So this whole advantage that I was talking about in the initial point would kind of be offset, because if you need an expert at point of care, you're literally saying that you need this radiologist who was there in, say, UAH hospital to be there at every point of care, which is literally not feasible. So the first challenge is somehow to decouple these two. So the scanning takes place at one place, it gets interpreted, and then it goes to the radiologist. So this is kind of the model that we are trying to introduce here. Because this problem of not having experts is very much, and people usually, it's interesting to note that it's pretty much even a first world problem. In Canada, you have only, say, 7 radiologists per 100K population, right? So if you look at it as proportion, you know now why the waiting lists are so crazy long. So how are we going to do this? We are basically trying to use some key tools here. The first, of course, is artificial intelligence, which is what we are trying to use to interpret these images. The second most powerful thing we are trying to use is the power of cloud computing, because that's how we actually remove this dependence of having the expert on site. Because with cloud computing, if it's a cloud-based app, all you're saying is at point of care, a nurse or your family doctor can take this ultrasound scan, send this to the cloud, this gets interpreted from the cloud using AI, and we can generate an interpretation of this ultrasound image into a report. What is even more interesting are some of the 3D visualization technologies that we use. The reason we highlight this very much is because one of the biggest challenges with ultrasound is the common kind of ultrasound is 2D, which is basically like taking one single slice. So you're using a handheld device and trying to take one slice into a tissue. Now, based on how you pivot your hand, your image changes a lot, which is why we would actually prefer to have a 3D device which basically looks at the whole thing. Like if you were to compare it, it's more like a video. you are basically taking, and we actually prove that it is much better for a non-experienced person to take a 3D ultrasound than to take a 2D ultrasound, which I would be touching upon in the subsequent slides. So these would be the three key areas that our research and all our developmental works revolve upon. Now let me just start with an actual use case. So this is the first product that we're trying to introduce. It's for a condition called hip dysplasia, which is a very common condition that's seen 1 in 100 infants. It is a deformity of the hip joint at birth. What happens with the hip is basically a ball and socket joint, and in some infants it so happens that the socket part of the joint is poorly formed. So when the child tries to walk, it just trips. So it's pretty much like standing on a table or a chair that basically has 3 legs. So because it's not balanced, the child would basically start tripping. Now, the issue right now is that this is not diagnosed, because if you diagnose it, the treatment of hip dysplasia is very effective and very simple. All you need to do is put this child inside a cast. It's called a Pavlik harness. It's basically just a cast, and the bone remodels itself. But the key thing is to diagnose this early, because if it is missed, then the only other point you would be catching this is if the person presents himself with some kind of problem with the knee. And so right now, and this was actually a startling study, that we found that 9 out of 10 DDH is diagnosed at adolescents. So that approach of the cast does not work anymore, because you're talking about an adolescent whose hip is completely dislocated. So he has to go through multiple surgeries. And now if you look at exactly how much this is costing the healthcare system, it's of the order of $1 billion a year, just because these are not screened at birth. Why is it not screened at birth? Well, it's simple. You don't have experts at each point of care to screen this at birth. You need a system that needs to automatically say if the hip is dysplastic or not, and then send this report to a radiologist. And this is why we identified this as our first use case. And another motivating factor is that in some cases it's even worse. People don't catch it at adolescence. It only happens when you have premature osteoarthritis. And it's actually found that hip replacement in the lower than 60 category, 30% of that, so that's 1/3 of hip replacements, are exclusively because of DDH, which was basically not screened at birth. So that was a very potent use case to us, and it's very common, unfortunately, in Canadian populations as well. So this is why we chose this as our first use case. And now let me move to some of the stuff we actually have on the application. So ARIA is automated real-time intelligent assistant. So the typical flow is, what you're seeing is a scan of the hip, which is acquired at a clinic. So it's acquired by a sonographer. So it's an ultrasound scan, so you have to imagine it 90 degrees shifted. So this would be the head part, and this would be the leg part of the baby. And this is the ball and socket portion of the joint. It's not very clear until and unless you're a radiologist, and I could totally be making that up. Yeah. But all the same, so this is a hip joint, and what we try to do here is try to identify these portions. So you have the socket portion and you have the ball portion. And the key thing here is, instead of looking at one single image, you're actually looking through this entire slice, entire sweep. And this was my earlier point, that if you were to take a single shot of that video, based on where you freeze, you will get a different image, which is why we analyze this whole thing as one single continuous sequence of frames. So based on this, now we run the AI, which I'll be explaining in a bit, and then we generate these models, which is basically a delineation of these two parts of the anatomy. And then we do these measurements that doctors are used to, which is basically the angularity of this bone and the ratio of how much of this ball part is covered by the socket. So these are some of the measurements. So the angularity is what we call the alpha angle, and coverage is the coverage of the bone. And at the end of the day, what do? We basically give a probability of how dysplastic this could be. So in this case, we're saying this is 99% normal, so absolutely no issues here. And so it is, at the end of the day, this is a suggestive diagnosis, which is one aspect of our model. So this is always still going to be human being in loop. So the final call still goes to the radiologist, just that we are cutting down time by automating this whole process. So it's saving time and saving money. And if we are right 98% of the time, the rest 2%, the doctor can always make this modification and take the call. So this was a quick demo. And now I'm going to share 3 studies that we actually did around this use case. And since this is a global issue, we basically did a multi-center study. So one was in the UAH hospital, and the other is the Children's Hospital of Philadelphia, which is actually a very high volume center for ultrasound scanning in the US. And then we also have NUH, which is one of the biggest hospitals in Singapore, and then Royal Children's Hospital of Melbourne. Now, so you can see that this is actually a really wide global spread. So we're basically trying to avoid any kind of bias that could happen from taking it just from one center here. So this first study that I'm going to present was on 1,780 hips. And the objective was basically to identify whether the hip is dysplastic, which is the abnormal case, normal, or if it is somewhere in between. So yeah, and before I go into the results, let me just say a few things about why the data set was so unique from the Canadian population. So one of the clear things that differentiates the Canadian population is the ethnic diversity. And so even if you were to take 1,000 images from, say, somewhere in Asia, it would be exclusively an Asian population. While if you take that from Edmonton, you have a much better spread of various ethnicities. So it makes the data less biased. Edmonton is a massive source of data. I mean, the UAH hospital and Canada in general, because one of the reasons is because of our wonderful healthcare system, because diagnosis is covered. So it was surprising to us that when we tried to get images from the other side of the border, it was not as easy, because diagnostic procedures are charged, and that actually results in having only a very limited subset of people actually going for the scanning. So in that sense, it was great to get data from Canada. And it's applicable broadly because of the same point that I said, which is basically that this is an ethnically diverse population. And let's see if this works in theory. So the first comparison was between expert radiologists and between R3D. So expert radiologists is the one on the right, on the left. So basically you see that a significant proportion of these hips were normal. There were the dysplastic cases, which the experts flagged, and the experts are pretty good at flagging it. They are pretty good at interpreting it. So when I say experts, I basically mean radiologists who have been in this profession for 20 plus years. But even with them, they seem to be having this yellow zone here, which they call borderline, which are not exactly dysplastic, nor are they normal. So essentially, the person comes back for a follow-up scan. Now, this was the category that we were actually able to improve upon. So if you look at the results of the automated 3D, we were able to classify the normal and dysplastic as well as the expert. Of course, we couldn't get better than an expert of 30 years, but we could cut down on this ambiguity. And this is, again, a huge difference in terms of time, because you're basically saying that there was this whole segment here which had to come for a follow-up, but with this automatic system, you have resolved it into one of the 2 categories here. And the next thing was to see how accurate this classification was to what is considered as ground truth. And we found that all these categories so if you were to plot this in terms of sensitivity, it was 100% sensitivity. So we were able to pick each of those dysplastic hips. So this was actually a study that we are really, really proud of. And now the next step, so until this point, so this was the first study and we were dealing with experts. Now, as I told you, the whole point is that you don't have so many experts around. And you basically need to see if it's going to help the novice sonographer, so someone who doesn't have that 20 years of expertise. Because it starts with problems with holding the ultrasound transducer, taking applying the right amount of gel, applying the right amount of pressure, holding it at the right location, and basically getting it at the right angle, which a radiologist might do blindfolded, but with a novice, you get a lot of variability. So we just did this study on a pilot set, so a much smaller subset. We basically tried to see how the novice would first fare on 2D scans, which is the hardest scan to do, and they basically pretty much messed it up. So you can see that this is the expert diagnosis, which we consider as ground truth. And here is the study of a novice sonographer. So you can see that there's hardly any correlation between these two. So they're basically trying, it was basically terrible. Next, we gave them the 3D probe, and with a minimal training of 1 hour. So first we trained them for 1 hour to see if they could do the 2D scan, and then we do this training for 1 hour to see if they can do this with the 3D scan. And these are the results that we get from the 3D scan. And as you can see, the normals are pretty much exactly where it was with the experts. It was a pilot study, which is the reason, in case you're wondering why we don't have the border line. The border lines were also classified into normal. And so that was the only difference with the expert radiologists in this case. So the take-home message here was that our initial hypothesis that 3D is indeed an easier scan to perform gets validated here, because with a novice, you actually find this difference. Now, before I go to, oops, how do I go back? Yep, that's good. Thank you. So this was the third segment of the study, which is the latest study that we are trying to publish right now. So just to summarize the stuff that I was basically mentioning, the first study was 3D for experts. The second was basically to prove for novice you can do a better job with 3D. But still we have one problem, which is that the 3D probe in itself is quite expensive. And it's not as commonplace as this 2D probe, which is the reason why a lot of centers still stick to 2D. So what we tried to do is to find if there is a way to use this 2D probe which is low cost and still give the same kind of accuracy as a 3D. And so you can always get a volumetric image from a 2D probe. You can literally just sweep this image across the tissue. So it's a handheld sweep. The challenge is that the spacing between each of these 2D slices is unknown, as opposed to a 3D transducer, which is well calibrated. So we just wanted to try and see how things go when we move on from the 2D probe, from the 3D probe to the 2D. And what we found was, interestingly, our accuracies are still comparable. It's still comparable to what we get with the 3D ultrasound probe. And the same trend of reducing the borderline cases, which we saw earlier, was repeated. And this time we could also reduce almost 89% of these borderline cases. So this was really a fascinating result for us. Now let me just try to explain how we do this. So here I'm trying to explain the workflow of what happens in the demo that I just showed you. So how does it generate the 3D image? Now before I get into the workflow, the first thing is with AI, the commonest thing that people could do is, if you have a data set, you just match it to the output, right? So you basically have a diagnosis. Just send in the ultrasound image and hope that the AI basically gives us the diagnosis, which is basically this flow that I'm mentioning here. So ultrasound sweep provides a diagnosis. We do not do this, because the moment we do this, the radiologist is going to ask us the question why. So the moment we say that something is abnormal, the first question is why, which I'm sure Mansoor will definitely be mentioning a lot about this problem in his presentation, because it brings the topic of explainability in AI. This is basically I would say a way in which we basically do it in a modular fashion. Instead of using a complete black box approach, we basically try to replicate each of the things that the radiologist does. So instead of saying that this is the scan and this is the diagnosis, we do each and everything that the radiologist is trying to do, which is first trying to segment the relevant region inside a slice, combine this for the entire slice, and then calculate the measurements that radiologists are used to calculating, which I earlier showed. and then provide the suggestive diagnosis. And so this whole thing is what goes into the report. So it's, in every sense, it's an informed decision that the radiologist gets to make from this workflow. And what exactly do we do in terms of the AI? This is a very common segmentation network. It's called the UNet model, U for pretty much for the shape of the network. What it actually does is you start with an image, which is it could be a multidimensional image, so it could be basically 2 dimensions plus a third dimension of space. So it could be a 3D image at this location. Now you pass it through the convolutional layers. So at every layer, you basically are trying to have kernels of different slices, and then you compress the image. So this is basically called the encoding path. So in this path, the central idea, without going into much of the details, the central idea here is basically to get a minimal low dimensional representation of the image. So that would, so you're starting with a high dimensional subspace and you're coming down to a very low dimensional subspace. So this basically compresses the information. It's basically called the what part of the image. And now from here, you're basically trying to reconstruct it into a mask. So from this lower representation, you go back all the way to construct a mask of the region that's relevant in the image. So this is actually a very popular network that's used for segmentation. The good thing about the UNet model, we did make a few modifications to this model. The thing that we always like about the UNet is that it can be trained on a very small set of images compared to bigger networks. There are much more complex networks out there, but UNet generally trains with a much smaller set of images. One possible explanation is that this encoding and decoding path enables learning to happen in this latent space, which is actually much lower in dimension, which is one possible explanation. Another reason for the success is this step, which is basically called copy and crop, so which encodes the positional information, which makes sure that your encoding and decoding path are basically looking at the same spatial things. So this is one of the models that we used in our work. So yes, that's about it in terms of what we have done till now. So now the next portion is where do we go from here? So the first target for Medo is now the FDA approval. We just realized that it's technically incorrect to call it approval, so it's FDA cleared, and so we're trying to go for FDA clearance, and the target is to do that by the end of this year. And so we are at the final stages of the submission. And what comes next? So HIP was one use case. The more interesting use cases are things like thyroid that come up next. So thyroid is a very interesting use case in the sense that it's a very common scan. Lots of people get thyroid scans, and unfortunately almost anyone would have nodules. Good news is more than 90% of these things, 95% of these are benign. So it's just what they call cysts. However, this kind of leads to a lot of overtreatment, because any person who goes in for the scanning, people err to, generally doctors would err towards the side of caution and send this person again for a biopsy, which is a very complicated procedure. It's an involved procedure, and it comes back as normal, of course. And so it's a very interesting use case wherein the biggest challenge is to reduce the false positive rates. So basically try to see if we can give a better suggestion to the doctors to whom to send for biopsies. And another thing that's interesting about thyroid is basically that when it comes to my earlier use case, my ground truth was derived from an expert radiologist. So a common sense-based reasoning would say that it's very hard to go one higher than the doctor there. But in this use case, on the other hand, we're actually trying to map it to pathological outcomes, which is considered to be a higher level of truth in the medical world. So this is actually one application when hopefully we do one better than the experts. And fatty liver is another use case wherein the objective is to identify if people have taken fatty livers and basically tell them to have less beer, so which I don't know would work, but then that's our next use case. Now, so I think I'm trying to introduce a few open challenges that we ran into, which is, I know it's not in any way limited to the problems that we had in our applications. It's more a general problem in data science. So one of the things is medical data is kind of the archetypical example of data imbalance, because almost always your abnormal condition is going to be a tiny subset of the entire data set. So you have a hip data set of 10,000 images. The ones that have the abnormality will be typically around 1,000. So if you're looking at it, it's going to be 1%. And any classifier is basically going to err towards saying that it's normal. So this is actually one of the main challenges that we are dealing with. The same thing happens in case of thyroid nodules. It's great that only 10% are malignant, but when it comes to a classifier, having just 10% of your positive use case is not ideal. So you have all kinds of problems of dealing with data imbalance. So the objective of these is basically to shoot out ideas, and this is a totally interactive thing. So I hope that you guys might have interesting problems that you could share with me after this. So one is unbalanced data. Another thought I would like to float in here is about the unlabeled data. And this is also, again, not limited to medical imaging, but in medical imaging, its effects are more severe because labeling in medical imaging requires experts. And you have to pay these people to do the labeling. So compared to a natural image where you can actually have a crowdsourcing project on the internet and people just click randomly and you're identifying natural objects, in medical imaging, you actually need somebody who is trained to do those annotations, which means that it's expensive. So out of the entire data set we have, typically 90% is unlabeled. And one question that we keep asking ourselves is there a way that we can actually use this? That's the first thing. Another question allied to that is there a way that the network can actually tell us which is the next image that needs to be labeled? Because you keep labeling, one real problem that you face is you could keep labeling thousands of images, but most of the time you're giving the network exactly the thing that it's already learned. And so it doesn't improve with data. I mean, people usually have the analogy of rocket and fuel, but it also depends on the kind of data that this network has already seen. So this actually opens the area of active learning, which is a very active area of research. And this is one of the things that we are really interested to see if there could be thoughts around, if there are ways in which we can actually have networks that basically not only learn the representation, but also learn what would be the next best one to fit in to give a more optimized result. So this is one of the open challenges that we face. Okay, towards the yeah, and again, just some of the issues that we usually face. This is the issue of what is called a calibrated probability. So in all these applications, we give a number, and most of you might know about this. What we get from a softmax layer in a neural network is a number between 0 and 1, but it's not a probability. It's basically just a number between 0 and 1. Why do I say it's not a probability? For example, if you take the output of any classical classifier, just take this number between 0 and 1, it gives a 0.6. You're probably going to label it as a 1. But now, if you were to take the actual data set, take 10 cases which give a 0.6, would you actually get 6 of them to be labeled as the positive case? Perhaps not. And this is what you actually call a problem with calibration. And the reason we run into it is, again, because it's medical. So every number we put there needs explanation. So the moment you put in a number, what does it mean? Does it mean that out of 6 of these people that I call as abnormal, out of 10 people, if I call it as abnormal, 6 people would have the abnormality? So this is one of the areas that we are working on, and this is one of the approaches that people have tried is something called soft labeling, which is basically instead of using what we call hard labels of 0 and 1, so this class or the other, basically say that this is probably 90% abnormal and 10% normal or 50% normal. So that's one approach that people have explored. So this is another area that we are really interested in. Another point is about the ground truth in medicine, which is actually a very, very challenging issue, because whenever you have something as ground truth in other domains, it's something that's measurable. But in medicine, it's usually actually the judgment of one radiologist. Now, you could increase that by having multiple radiologists, but it opens the possibility of what happens if you have a radiologist apart from your cohort that you have got your data from. So this is another interesting problem. And in general, to summarize my talk, the takeaway with all these open challenges is sometimes it's also a question of phrasing the right questions for the medical application. Sometimes the answer does not lie in actually just solving it the way the radiologist solves it, which is one of the classic examples of that is basically trying to use something like a pathology data set, which is apart from what is in the medical domain. Sometimes it's only a modification in the workflow. What exactly in this adds value, you never know in a general sense, but what we try to do in Medo is try to identify this first and so try to see where is this area that we can add most value and try to go in towards that direction. So that's all from my side, and it's open to you guys.
So any questions?
Sure.
Hi, excellent presentation.
Thank you.
Curious question. I hear radiologists and I hear improvement and I hear streamlining through what Medo.ai is doing.
Sorry, I couldn't hear you.
I hear in your presentation radiology,
Yeah.
and then other end Medo.ai.
That's right.
A solution for that. So why only radiology? I'm looking at another application with, let's say, echocardiogram, which is ultrasound. Is there any way that Medo.ai could improve the analysis and outcomes of echocardiograms, which is ultrasound based?
Well, absolutely. So basically the question was why only the radiologic applications, why not other applications in the field of medicine? Of course, yes. I mean, AI is a tool, and it's only a question of which one first. It's only a question of which one first and which we see as a low-hanging fruit at this point. But 100%, there are a lot of applications in the medical space. So this reminds me of one of the talks I was listening to from Google Health, where they actually made a really interesting observation that they were trying. So essentially what they were saying is sometimes there are these very interesting problems that are related to the workflow that doesn't have anything to do with AI, but actually adds a lot of value. So that's another potential area. There are lots of other potential areas. I totally agree.
So how do you choose your next challenge? Like I see thyroid and I see, fatty liver. Is it because there's a plethora of good data sets to work from? Because but you have the heart center here, and they have a plethora of great data as well. So that begs my curiosity because heart would be a huge market for you, right?
It's, the short answer, heart is a huge and crowded market.
Right.
Like it has plenty of people already trying to do that.
Yeah.
I mean, I'm not saying it's not a challenging problem or not that it's a relevant problem. It is a relevant problem that's being worked on by a lot of people. Now, how exactly do we identify our next use case? It's more of a strategic decision, so to say. So if you were to think even about the two that we identified, and I put it in the order of thyroid and liver, but liver was actually a project that we started way earlier. So we actually started that almost 1 year earlier, but it is also based on the feedback that we get from radiologists. Because with thyroid, the reason we picked this is we spoke to clinics. Some of you might know about the MIC clinics, which are one of the biggest collaborations of radiologists in Canada. So once we spoke to them, what was their pain point? So the moment we discussed about thyroid, the overwhelming feedback was that this is a mess. Anything you do is going to be better. Because the reason in an application like thyroid, a lot of the information that needs to be documented doesn't get documented because of problems in the workflow. So that's one of the motivation factors that we have. Like it's not only how much of data we have. To be honest, we are actually fortunate because we have ethical approval for retrospective data collection. So we can literally get data for almost all these use cases. As long as that's one of the good things about being located in Alberta, because every data center, essentially, like be it a clinic, comes under AHS. And once you have an ethical approval from AHS, you're looking at one central repository of using data for training. So data is not the problem. The problem is actually where can be the quickest value add.
Thank you.
Great. So yeah, so we are actually in the process of finalizing the clinical protocol. So we are actually just submitting those documents. So it appears that there's no magic number for the FDA. There's literally none. And right now, we, as a ballpark figure, which we have used in our earlier publications, we are going with 1,000 cases, which we have used. And yeah, would it apply for other countries? Well, not exactly. For, say, for example, for Canada, we would have to go through the Canadian system. For Europe, it would have to be the CE regulations. But one of the reasons we chose FDA first is because it turned out that FDA is perhaps the hardest one to get. And the fact that you even have an FDA pending status kind of puts you in a favorable spot when you go for the other applications. Like, say, for example, in Southeast Asia, if you were to try, the fact that you have an FDA pending kind of helps, because it's a rigorous process even to get to the first stage. Sure.
Question, maybe you could tell us a bit about your team, technical team.
Sure, sure.
And also, maybe if it's not a secret, tell us about your investment.
About
your season investment.
Oh, about the investments. Yeah, sure. So let me start with the technical team for sure. So yeah, we basically have two teams. It's a web application. So we have a web development team, which are a group of software engineers. So we basically have 5 people in the team. And the AI team is the team I directly work with more closely. So in the AI team, we have almost 10 members right now. And we are really fortunate to have the computing science department right here. So a lot of our team comprises of students who are hired as interns, who are actually our employees and who are the ones who do this. So yeah, we work with these labs in comp science with, for example, Dr. Russ Grainer is a popular researcher in this area. So we work with Dr. Russ Grainer's lab. We work with a lot of professors in computing science. So that's what actually comprises of our technical team, so to say. Going to the harder question of investment, yeah, no, it's not that hard. Honestly, like we closed our seed rounds of investment last year. So to give you a bit of the perspective, Medo is a Singapore, Canada-based startup. So all our seed round investment was in Singapore. So our investor, we're not allowed to disclose exactly who, but it was through an incubator environment that we had in Singapore, and it was a process of around a year. And so last year around this time was when we closed our seed rounds. And we're basically looking at 2 years from now is when we're looking at what is our Series A, which is the next main round of funding.
Yeah, we're running tight on time. Maybe one more question and the presentation, but
Sure.
then after you can still ask more questions.
Okay, so going back to your issue with 3D, converting 2D images into 3D, can you not add some like accelerometers to get time data onto your sensors and then use that to create a better image?
Absolutely. I mean, yes, that's one way of doing it, to have a sensor attached to the probe, which accelerometers we have tried. The only issue is that we're looking at absolute precision and absolute position of the device. And with accelerometers, you get a lot of drift. So if the transducer is just held in position, just because of the way in which accelerometers are not calibrated, there's a lot of drift in position. So what we had tried instead was the optical way, so which is essentially the same idea. You're changing the sensor, so you're basically attaching sensors to the probe and trying to pick the location, which was quite successful. The only thing was we were thinking how could we do it without a sensor, and yeah, this was one of the interesting works we did last year, which was trying to use a 3D probe as this calibrated device. So this is one of the techniques we have patented, which is a way to basically use a 2D sweep, calibrate it using a 3D ultrasound probe, which means you know the spacing there, and you use that for the training, and then use that same technique on the probe. So yeah, that's definitely something that we are looking into. Using a positional sensor, yes,